Anyway, so I'll introduce myself. I'm Murray Grossman from the Department of Neurology at the University of Pennsylvania, and I'm going to give a brief overview of frontotemporal dementia. So, this is, I think, an appropriate place to start. That is to make sure that we're really talking about frontotemporal dementia, and there are a variety of issues that really should be addressed when, at the beginning of this journey that we're all on. The first is to make sure that you rule out other conditions that can mimic frontotemporal dementia, or FTD. The first thing to do is a clinical exam from an expert. That's, I think, an important place to start. The expert should have a lot of experience in frontotemporal dementia and related conditions, and oftentimes this is the kind of thing that we folks like me specialize in at various centers around the country. It's important to make sure that you have some blood tests, including things like B12 deficiency, evaluation of thyroid functioning. In this area, we're worried about Lyme disease. All of these are conditions that can mimic frontotemporal dementia, and it's important to make sure that none of those is causing the kinds of difficulties that you're seeing. We also tend to perform what's called a lumbar puncture or a spinal tap. We do this because we want to rule out rarer causes of FTD. We've had, over the past 6 months, a couple of folks who've come to us with that diagnosis and have ended up instead having an abnormal collection of cells, lymphomatous cells, in the fluid that's around the brain and the spinal cord. So we think this is an important kind of diagnostic procedure to do. Finally, we think it's important to have a high-quality imaging study. We use MRI scans. It's important because there are several conditions that can mimic frontotemporal dementia. This is a picture of an MRI. It's a slice through the brain. The front of the head is here. The back of the head is at the bottom. So you can imagine this is a slice through the brain with somebody lying on their back, and you're looking down on their head. This is the left half of the brain. This is the right half of the brain. This particular individual had significant difficulty with language. Language, many of you know, is represented in the left hemisphere. And what you can see here is some exaggeration of this white area around the frontal part of the left hemisphere. You can see some enlargement here of the fluid-filled areas in the center of the brain called the ventricles, and you see this enlargement here and the white here compared to the right side because the darker areas, this is the brain areas, have become smaller. They've become a little bit atrophic because the brain cells in these areas are not functioning as well as they ought to, and so we're seeing an asymmetry, a difference between the left and the right hemisphere that is consistent with the diagnosis of FTD. The mean age of onset of FTD in our cohort is about 61 years of age. The range is extraordinarily broad. We see folks as young as 30 and folks as old as 82 presenting with frontotemporal dementia. So this is really quite unusual. The average is about 61, so above and less than that age, you get a tailing off of the frequency. So it's different from Alzheimer's disease, where as you get older, you see larger and larger numbers of folks with Alzheimer's disease in the population. FTD is not a rare condition. It is, among people under 65 years of age, almost as common as Alzheimer's disease. So it is not an unusual condition, and the work that AFTD and that the Alzheimer's and Related Disorders Association is doing to bring attention to this condition, I think, is very important, timely, and appropriate as we're discovering what a prominent role this condition plays among folks who have neurodegenerative conditions. This is the natural history, what happens during the course of the condition. We find that if this here is disease severity, and this is the months of the duration of the condition, you can see that there is a decline over time, but that decline over time is not linear. It ends up that in the mild stages of the condition, the mild stage lasts for over half the duration of the condition. So we think, based on our research, that there are compensatory mechanisms that allow folks to do well early on during the course of the condition, but these compensatory mechanisms become overwhelmed, and over time, during the moderate and more severe stages of the condition, you can see that there is a more rapid and accelerated rate of decline over time. There are two major ways in which frontotemporal dementia presents. One is as a disorder of social comportment and difficulty with what we call executive functioning. This is planning and organizing and attention, and I'll talk about these in just a moment. And the other way that FTD presents is as a disorder of language or aphasia. We refer to this as progressive aphasia because the language disorder or the aphasia gets worse over time. And we refer to it as a primary progressive aphasia because it's not due to a stroke, it's not due to anything we can see on an MRI scan. Instead, it's due to the fact that the brain cells themselves that are important for language are having increasing difficulty over time. In our series, we find that about 60% of folks have a disorder of social comportment and personality, and about 40% of people have a disorder of language. And this is relatively representative of the three other centers around the country where a lot of patients with FTD are seen. Let me now describe for you some of those syndromes. First, I want to talk about the disorder of social comportment. Many of you may recognize some of these features. There's difficulty with self-regulation, impulsiveness. Folks can be quite disinhibited. None of this is necessarily occurring because of purposefully wanting to do something bad, but folks will walk up to strangers on the street and start a conversation and say, "Hi, how are you?" Or start playing with a stranger's child and bouncing up and down and saying, "Hi, how are you?" Because they like folks, they like babies, they like people. It's not done with any bad intention, but it's something that we just can't inhibit. There will be impulsiveness. See something that you like and go for it without really thinking about the consequences. Sometimes this can be tough because if what you're being attracted to is on the far side of a busy road, then you have to be very, very careful. There are also some impairments of social conduct where people don't recognize that it's not necessarily appropriate to walk up to a stranger in a restaurant and clap them on the back and say, "Hi, how are you?" like some politicians do. Sometimes folks can be quite insensitive to all of these kinds of things, and sometimes when folks can't get redirected, they can become quite agitated and when they're trying to go for what they have in mind as a goal. This relates to some of the rigidity and some of the obsessive behavior, some of the rituals that folks get involved in. People might have a particular way in which they like to eat. They'll only eat peas and line up the peas on a plate and eat the pea one at a time in a particular order and eat every meal this way. Or some folks may like to eat only chocolate-covered donuts. Many of you may like chocolate-covered donuts, but that's still not a great way to get a variety of food into your diet. Other folks, while I've been talking here about behaviors that are very active and can be intrusive, can be apathetic and unmotivated, can be quite happy sitting in a chair all day, looking at the same page of a newspaper and doing nothing else and apparently not dissatisfied. And as a caregiver, you may walk up to your loved one and say, "Come on, let's go. It's time to go shopping. Let's go." And they'll look, and you have to say after another 30 or 60 seconds, "Okay, let's go. Time to get going." And they look. And then you try again, and you try pulling on an arm, and it's tough to get people going sometimes. And this is not because folks are trying to be purposefully uncooperative. Instead, it has to do with the part of the brain that is important for motivation and for getting going. There can also be a syndrome that neurologists talk about that's called Kluver-Bucy syndrome, and you may recognize some of the features. This is related to, again, a part of the brain that's called the temporal lobe. There can be hyperoral behavior where people will shovel in tons of food into their mouths, so much so, in fact, that it's difficulty to swallow, and it puts people at risk for aspiration, food going down the wrong pipe into the lungs. Sometimes we can see hypersexual behavior. This can manifest itself as an infatuation with the starlet, collecting pictures of your favorite actress, or it can get involved in other kinds of inappropriate behaviors, such as masturbation in the dining room, which is not terribly appropriate, not really appreciating that this is not an appropriate behavior. There can be hypervisual behavior, walking in a grocery store or a pharmacy and seeing a nice little shiny object and dropping that in your pocket because it looks nice. And then as you're leaving the store, you look over and you see that your loved one is kind of looking at something, go, oops, what's this? And we have to go back and pay for it. They don't understand this. And I've certainly had some folks I've taken care of who've been picked up for shoplifting because of this behavior. And there can be unprovoked rage. None of you, I'm sure, have seen this. This oftentimes takes place at, when you're driving on the highway, or if there's a traffic jam, and folks will go on the side of the road, and all of this stuff can occur and unfortunately manifest itself while driving. This is an image of the brain. This is the left side of the brain. This is the right side of the brain. These images down below represent a slice down the middle of the head, and you take the two halves of the brain apart, and we're showing you the center of the brain. This is the frontal part of the brain here, sits right behind the forehead that's there. This is the temporal lobe down here. You can imagine the eye right over there. This is the back of the head, this is the occipital lobe, and this is the parietal lobe. There are 4 lobes in each hemisphere, and there are 2 hemispheres in the brain. And what we're illustrating here in these red areas represent areas of the brain where there is significant atrophy or shrinkage of the brain in folks who have this kind of disorder of social comportment and personality. Let me give you an example of some of the studies that we do to try to understand why this kind of problem occurs. This is a picture of me trying to do some repairs on the weekend. And you can see my son down here looking on in amazement, sees me holding on, and we ask folks what will happen next. And here are some choices. I think you can see these here. One is my wife comes rescuing me with the ladder. And this is usually what happens, by the way, for those of you who know me and my wife. Sometimes she could be busy elsewhere, and I'll have to extricate myself and climb up on the roof. And the third possibility that sometimes happens, although this is not appropriate, I try to tell my wife this, that they come and laugh at me. So we ask folks to tell us which is the best outcome after this, what should happen next. And what we find is that folks with a disorder of social comportment and personality are essentially random. They do not understand that this here is the right kind of response. And when we look at the kinds of errors that people make when they're making decisions about what should happen next, we find that oftentimes they're choosing this kind of answer. So there's little appreciation of what should happen in these kinds of social situations. And other cartoons include things like what should happen if you find a fly in your soup, or if there's a problem with the bill in a restaurant. When we looked at how this correlates with the areas of the brain, we find that this temporal part of the brain and this frontal part of the brain are intimately involved in making this kind of social judgment. And we know that these areas of the brain are compromised in folks with frontotemporal dementia. To add insult to injury, oftentimes, while there are a variety of these behaviors that I described that can be difficult to manage and can be intrusive, what's quite frustrating for all of us is that there just doesn't seem to be insight into the fact that some of these behaviors are appropriate. And we've asked many of you about this, where we've asked you to give us your judgment of behaviors like impulse control, empathy, self-monitoring. And this is a 0 to 100 scale, where 100 is good and 0 is doing poorly in this domain of functioning. The brown histograms represent your judgments. The blue histograms represent your loved one's judgments of how their own behavior is doing. And what you can see here is that there is a consistent discrepancy where patients with frontotemporal dementia consistently think that their behavior is fine and have little insight into the fact that some of these intrusive behaviors or the impulsive behaviors are, they don't appreciate that they're not appropriate. And we find this is present in 11 of the 15 social domains to a significant extent. So folks will overestimate how well they think that they are doing. What are some of the treatment options that are available? Well, certainly there are medications that are available, and we use these medications, we think, very effectively to help manage some of the behavior. This includes some atypical neuroleptic agents. These are quite useful at helping out as far as dealing with some of the more intrusive behaviors. We use anticonvulsants to help those, some of the atypical neuroleptics work much more efficiently. And we find that the combination of these two is sometimes necessary and quite helpful. Also, we use a variety of antidepressants to help out. This isn't specifically for the antidepressant effect with which this medication was originally intended, but instead we take advantage of the fact that these medications help supplement one of the brain chemical systems that's called serotonin and help that system work better. There are also a variety of behavioral things that you can do in terms of structuring the environment and helping out. And these are things that are just as important. These are the kinds of things that help these medications work effectively. And so I can't emphasize enough how important this is. And Lauren Massimo will be talking more this afternoon about these behavioral management issues. One kind of thing that we think is very important is having a structured environment, having a schedule. This relieves the burden of decision from the patient's shoulders, and if you can structure the environment so it's a dichotomous choice, one thing or the other, or a yes or no decision, or have a schedule so that people don't have to make decisions. We make decisions all the time in our lives, and if decisions are overwhelming for us sometimes, they're even more overwhelming for our loved ones. And so structuring the environment can be very, very effective. A curriculum of activities can help you and can help your loved one, and actually writing out a series of activities every half hour, what you want to do in the morning from 8 to 8:30, have breakfast, 8:30 to 9, relax after breakfast, 9 to 9:30, go for a walk, 9:30 to 10, work on a crossword puzzle or work on a jigsaw puzzle, 10 to 10:30, etc. Build into that visits to the washroom if there's a problem with continence. And another thing is avoiding exposure to provocative agents. If your loved one is attracted to food, for example, or is attracted to a particular star or has some hypersexual tendencies, to help manage that kind of issue, take the newspapers out of the home that have lingerie ads, for example. Anyway, there are a variety of things that you can do to help reduce exposure to provocative agents that will help you out and will help out your loved one as well. There are also, as I mentioned, language problems that are associated with FTD. One variety of language difficulty is called progressive non-fluent aphasia. This is a difficulty of language expression, where speech can be hesitant or effortful. It can be like an old-fashioned telegram, and all those small little words that we use to string words together into a sentence, they all seem to drop out. Folks can have speech errors, including sound substitutions will occur quite prominently. There can also be speech apraxia, where there's groping to pronounce a word in the correct way. Sentences can be quite simplified, and these kinds of problems can manifest themselves as well in comprehension. Difficulty understanding grammatically complex or very long sentences, such as the one I'm saying right now. This is an image of a series of folks who have this kind of syndrome, and you can see these dark areas in the brain, mostly in the left frontal part of the brain, that are associated with progressive non-fluent aphasia. the speech deficits in PNFA have been studied in our lab, and you can see here that this is the number of utterances, and almost half of the utterances that the patients with PNFA produce include a speech sound substitution error. So they're really quite common. We also find that speech can be quite slowed down, quite effortful. I'm speaking at a rate of about 150 words per minute. Folks with a social disorder or folks with a semantic dementia, I'll talk about that in just a moment, will speak at a rate of about 90 words per minute. Folks with progressive non-fluent aphasia will speak at this speech rate, less than 1 word per second. It's not quite like that. The words will be in a burst, but I wanted to give you a feeling for the average rate of speech. That average rate of speech requires some patience on your behalf, and so that you can make sure that folks have an opportunity to get out what they're trying to say. As I mentioned, there can also be difficulty with sentence comprehension, and all of these difficulties correlate with atrophy or difficulty with brain functioning in the left frontal regions. And there's also a fluent form of progressive aphasia that is also called semantic dementia. This involves a great deal of difficulty with finding the words that you want to use, talking around what you're trying to say. There are also speech errors, and the speech errors in this condition tend more often to include substitutions of an entire word for another word. Lots of times, because there's such difficulty finding the words that you want to use, that there's also some content can appear empty. And again, there's difficulty with understanding words, and as the condition progresses, it's not just difficulty understanding words, but understanding the meanings of objects that are being used. Folks with this form of language difficulty will have the condition affecting most prominently the left temporal lobe. This is the part of the brain that's important for comprehension. As I mentioned, there's significant word finding difficulty, and folks, when they're first seen in our clinic, 2/3 of people with semantic dementia will have significant difficulty finding the words that they want to use. Again, it's very frustrating for everybody. It's frustrating for you to try to understand the message that your loved one is trying to give you, and it's very frustrating for your loved one to try to get that message out. And this is something that we see very early on in the course of this condition. And again, this is correlated with the condition affecting the left temporal lobe. Let me give you an example from a study that we did to understand specifically word meaning. This is a study about Louise and her father. Louise is a bit of a tomboy, and the father's explaining to her, "I want you to walk slowly in the hallway." But Louise does not listen because she is indeed a tomboy. She goes charging off, and she runs into the housekeeper. And then her father gets a hold of her, and Louise sees her father lower at her. You're hearing something that's kind of new in there. There's this word, lower. And we taught folks a new word. In fact, this is a very low-frequency word that really occurs in English. And we try to, after having gone through the story, to see what people understand about this word. We did this with a little task like this, where we show people a picture, and we give them 3 choices and ask them, well, what is this picture illustrating? And we find that folks with semantic dementia have profound difficulty understanding the meaning of this word, lower. Folks with progressive non-fluent aphasia, despite their language problems, really do quite well in terms of their comprehension. And again, folks with a social disorder are better than chance as well. What are the treatment options for progressive aphasia? There are some medication options that we use sometimes. This is mostly for dopaminergic supplementation. We borrow medications from Parkinson's disease to try to help out with speech fluency. We borrow acetylcholinesterase inhibitors from Alzheimer's disease to supplement the acetylcholine neurotransmitter system. There is some evidence that this is helpful in terms of word finding. We use these medications very cautiously in this population because there are lots of side effects associated with these medications. And again, there are a variety of behavioral management issues that you can do to try to help out. One is, don't do what I'm doing, speak slowly. Give people an opportunity to process what's being said. Use multiple modalities. Some of you may know me, I talk a lot with my hands, I gesture a lot. Use that for advantage. Give people multiple modalities of input when you're trying to express yourself. Speak redundantly. If there's a particular word that's difficult to understand, use a synonym. We have lots of words for the cup, container, glass, whatever. Use these other words. If somebody can't understand one word, maybe they can understand another word. Sometimes it's useful to have a personalized picture dictionary. Many of you have digital cameras. Take a picture of some of the objects that you need, that you have difficulty finding the names for. Print the name on the back of the index card and assemble a personalized picture dictionary to help facilitate communication. Don't use the complex grammatical sentences that I'm using. Use simplified sentence structures and give people an opportunity to focus on the attention to the conversation. Have the conversations in small groups instead of 12 family members all hollering something at the same time and trying to figure out what's going on. There are many causes of frontotemporal dementia, and the syndromes that we've described are due to the accumulation of proteins, as I've mentioned, in the brain cells. Some of these conditions we refer to as being tau positive. You may have heard of some of these specific histopathological abnormalities, Pick's disease or cortical basal degeneration. We call these tau positive because they're associated with the accumulation of this protein tau in the brain cells. Then there are a variety of conditions that are tau negative because these conditions do not have tau. These are referred to with a complex name because until recently we didn't know what was causing the problem. They're called FTLDU, or frontotemporal lobar degeneration, with ubiquitin positive and tau negative inclusions. That's all smoke and mirror and hiding that we didn't know really what was going on. We saw that there was this ubiquitin protein there, but we didn't know what was causing this protein to appear. And I'll talk about that in just a moment. We know that 30% of patients with frontotemporal dementia have a positive family history. You'll hear a little bit more about that later this morning. And in about 10% of these cases, we've been able to identify the basis of this positive family history. We've been able to identify a specific chromosomal mutation or chromosomal change. In some people, it's a mutation in the gene called MAPT. This is where tau is coded on chromosome 17. And this past summer, other researchers found another mutation just happened by chance to occur on chromosome 17 called progranulin. Chromosome 17 MAPT is associated with tau positive problems, and chromosome 17 progranulin is associated with tau negative disease when we look at our autopsy series. There are a variety of other chromosomes that seem to be associated with FTD as well. One called VCP, another one called CHAMP2B, and then there's a chromosome, a gene on chromosome 9 that we're just now trying to identify that's associated with FTD and a related condition, motor neuron disease or amyotrophic lateral sclerosis. And again, we'll talk about these later this morning. This is important to know, not for some abstract academic reason, but because there's a difference in survival depending on whether you have tau positive or tau negative pathology in the brain. We find in our autopsy series that there is better survival for tau negative than for tau positive conditions. This is the percent of survival. This is months of survival. And as you can see here, the average survival for the tau positive cohort is on the order of about 70 or 80 months. And in the tau negative cohort, the average survival is more than 100 months. And we think that this is an important kind of factor to understand and important information for us to be able to share with family members so that we can help with your planning. some of the things we've tried to do to figure this out in life is we've examined folks retrospectively based on our autopsy series who have tau-positive disease or tau-negative disease, and we find different clinical features. There's some folks with tau-positive disease who are more likely to have involuntary motor problems, such as myoclonus, or sudden jerky movement, or a kind of tremor. We see these much more often in tau-positive conditions. Tau-negative conditions are much more often associated with an impairment of language and with a social disorder. There are some young individuals who end up having Alzheimer's disease that we refer to as a frontal variant of Alzheimer's disease because they present exactly clinically like folks who have FTD, and we find retrospectively that there's more difficulty with planning and organizing and slightly more difficulty with memory problems. We find also in our neuropsychological testing, when people are first seen, this is again months of survival here, when people are first seen, the tau-positive folks have a great deal of difficulty with processing visual information, such as copying a geometric design. Tau-negative folks, again, this is survival, this is how well people are doing, and folks with tau-negative disease have significant difficulty with naming, and these difficulties are maintained during the entire course of the condition, and we can use these relative performance on these kinds of measures to help give us a hint, again, of whether somebody's more likely to have tau-positive disease or tau-negative disease. There are different distributions of atrophy. When we look at the MRI scans of patients with tau-positive disease, here you can see that the distribution of atrophy affects the frontal parts of the brain, particularly laterally, that is on the outside of the brain. And in folks with tau-negative disease, there's much more atrophy that's affecting the middle parts of the frontal lobe. And in the group of individuals who are mimicking folks who have frontotemporal dementia, but who have Alzheimer's disease in our autopsy series, we tend to find more problems in the temporal lobe. In our cerebrospinal fluid analyses, we find that tau, that protein that I mentioned, can be measured directly, and so this is really important, not only for diagnostic purposes, but also for purposes of seeing how well people are responding in treatment trials. And we find that patients with frontotemporal dementia have significantly lower levels of tau in the cerebrospinal fluid compared to patients with Alzheimer's disease. This is from our autopsy series, so we know what is causing the difficulty that these patients had during life. And similarly, when we look at cerebrospinal fluid in folks who are where we don't know what's causing the problem, but clinically have a diagnosis of FTD, we find that a large number of people have significantly low levels of tau in the cerebrospinal fluid. It's as if the brain is acting like a sponge and soaking up all of the tau, so it's not getting into the fluid. What about, I mentioned that there's this protein in FTLDU, ubiquitin, the tau-negative marker, is really a protein that surrounds abnormal proteins in the brain cells and escorts those abnormal proteins to what's called the proteasomal lysosomal system, where they get broken down. It's as if this is the carburetor of our brain cells, and it gets rid of, identifies and gets rid of all of the bad proteins. But we really didn't know what that bad protein is. Well, and this is important because perhaps 40% of individuals in our autopsy series have this tau-negative form of FTD. And what we found, and when I say we, it's really Virginia Lee's lab here at University of Pennsylvania, identified this past fall this protein TDP43, and this has caused a huge amount of excitement in the scientific community because now we have a new diagnosis, we have a new target for drug therapy. And this is extraordinarily important. And this TDP43 protein is accumulating abnormally in the brains of individuals with FTD. And it's not just brains of patients with FTD, but we also find the same kind of problem in motor neuron disease, or amyotrophic lateral sclerosis, Lou Gehrig's disease. TDP-43 plays quite a prominent role in the pathology of these conditions. Then there is a clinical overlap between motor neuron disease and FTD. We find that FTD is present in about 10% of patients with motor neuron disease. We see folks who have both a social disorder as well as an aphasic disorder. So we see the same variety, the same phenotype, the same presentation in folks who have the diagnosis of motor neuron disease. Likewise, in patients who have the diagnosis of frontotemporal dementia. In about 10% of cases, we will find that motor neuron disease is present. And so oftentimes we do a motor exam, we look for evidence of motor neuron disease in individuals who have frontotemporal dementia, and we'll get what's called an EMG, which is a study of the nerves and muscles to see if that's what's causing difficulty with controlling the muscles of speech around the face or difficulty controlling the swallowing reflex. About 33 to 50% of patients with motor neuron disease will have some minor, relatively minor cognitive difficulty involving either the planning and organizing, social judgments kind of things, or the language deficit. So even though there may not be a full FTD syndrome, there will be some attenuated version of that in a large proportion of folks who have motor neuron disease. And now we're starting to get a good handle on that because we've identified TDP-43. So I couldn't be here and say all of this without a wonderful group of collaborators in my lab and elsewhere. You recognize some of the names on this slide, and I also want to acknowledge generous support from NIH, from the Dana Foundation, several very generous private contributors, as well as you and the patients, your loved ones who've helped us with all this work. So thank you very much.